Good afternoon, ladies and gentlemen. I'm aware that there's a little overlap with some of the things that other people have already said to you, so I'll try to not repeat too much, but some of the important messages I think do bear repeating. So I missed this morning, but I'm sure we've all told you that actually cancer is not only quite a big problem for health services at the moment, but is going to be an increasing problem as time goes on. Not necessarily because cancers are getting more common, in fact some aren't, and my particular area, lung cancer, is an area where in men we've seen quite a big decrease in the incidence of lung cancer. The problem is that everybody is getting older, and people are generally living to much later ages and are still fit and well as they get into their 70s and 80s. And just because we have an older population and cancer is classically a disease of older people, we're going to be seeing much more in the way of cancer. And that makes it particularly important that we go into the next 10 to 20 years really having got our priorities straight in terms of where we need to invest our time and effort. And radiotherapy, as I think we've all said this afternoon and today, is really a very, very important part of our armamentarium against cancers. Within the patients that we cure of their cancer, radiotherapy has played a part for 4 out of 10 of those patients. And in terms of being the only or the major treatment involved for about 16% of patients who are cured of their cancer, radiotherapy has done that for them. Now, chemotherapy is still a very important part of the overall treatment plan, but chemotherapy on its own cures very few patients. And yet, because we have large pharmaceutical companies behind these drugs, gets an awful lot more publicity, and it does tend to be what you see on the news and what you read about in the papers, whereas radiotherapy traditionally hasn't got that sort of publicity, and I think there's been a misunderstanding about its importance. I'm just going to talk a little bit about trials in general before I start being very radiotherapy specific. And trials are really important because we don't have all the answers. We've heard a lot about some really clever, really whizzy equipment, some really clever ways of doing things, and there's a temptation to think that something that's new has got to be better. But actually, what we've been doing over the years, we understand, we can manage the toxicities, the side effects. It's the gold standard in comparison to what used to happen in the past. And new treatments have to be introduced quite carefully so that we understand the additional benefits and the additional risks of doing things differently. So trials are very much about continually improving the care that we're offering. There are a number of different sorts of trials, but in terms of scientifically being certain that it's the treatment that makes the difference, the gold standard trial is what we call a randomised controlled trial, which means that, unfortunately, it means that neither the patient nor the doctor can choose the treatment that the patient's going to have. So classically, the trial might be treatment A and treatment B, and the randomisation process will assign you to one of those two treatments. Now that's actually quite difficult, and this is where the concept of equipoise comes in. We can only do that if we believe that treatment A and treatment B are likely to be the same. If we believe strongly that one treatment is better than the other, then we can't do that sort of trial because that's unethical. Now it might be that across the country doctors are in equipoise, so it might be that some of us think that's going to be the better treatment and some of us think that's going to be the better treatment. But actually, by the time you've explained it to the patient in front of you, just in terms of what's involved in that treatment, the patient may actually have a really quite strong feeling as to which treatment they would prefer. So you've got to have not only the doctor to be comfortable with you having either of those treatments, you've got to be comfortable too. And that's quite difficult. And that's particularly difficult if the two treatments are very different. So for instance, We did a big trial for mesothelioma patients a few years ago where they all got chemotherapy initially, but then the randomisation, the trial question, was what does surgery add to the chemotherapy? So what we were actually asking patients to do was have no choice in a decision as to whether they would go on and have a major operation or whether they would carry on under their oncologist. And that's very, very difficult. That's a very big difference in treatments and a very difficult situation to put patients in. And I was always very surprised when patients were willing to help us with that. So this is to remind me to get back onto the topic of radiotherapy. You've seen lots of pictures of machines, so I won't dwell on that. What I do want to do is just talk about the fact that it's taken a little while, I think, we've had all the chemotherapy trials for a long time, and then all of a sudden there's been this quantum leap in what's available in terms of radiotherapy. And I think a few years ago it was recognised that research in radiotherapy was going to be a very important area for the UK, and a national body was established called the Clinical and Translational Radiotherapy Research Group to really try and drive forward radiotherapy research in the UK and improve the quality of the research. And that has 4 different work streams, and I'm sure there are a number of people in this room who are involved in those, and that's been really quite important in the last few years. So what sort of questions or what sort of reasons might we have for doing trials in radiotherapy? Well, the first thing is that we know that being involved in trials is a good thing generally. It shows that you're being treated in an up-to-date cancer centre, and also patients on trials do tend to get monitored a little bit more closely, do tend to get offered an opportunity to receive cutting-edge treatment. So being involved in trials is a good thing generally. The other thing that's really important about radiotherapy is you've heard we have all this very clever kit, and you've heard about some of the problems over the years where we've been very good at one bit of it and not quite so good at the rest. Quality assurance in radiotherapy is really important, and being involved in trials means that your department is being scrutinised really very carefully and very closely, and it helps you be confident that the standard of the radiotherapy that you're delivering is up there with the rest of the world. It allows safe introduction of new technology. We have had instances in the past, and I think there have been problems when radiotherapy techniques have been changed, or when, for instance, when brachytherapy and external beam radiotherapy have been used together for ladies with pelvic cancers that have damaged people, and it's been some time before those problems have been picked up. So it helps departments to safely introduce new technology. The specific questions we might ask ourselves when we're thinking should we be giving radiotherapy to this particular group of patients is, can we improve people's survival, the length of time that they're going to live? Can we improve the control of the cancer, because if the cancer's under control, that's going to make people feel better? And importantly, can we improve quality of life? Because whilst we've talked a little bit about the importance of radiotherapy for cure, I know this morning that Paula talked quite a lot about the importance of radiotherapy for palliation of symptoms, for keeping people feeling well, so that if that time is relatively short, it's good time that can be well spent with family and friends. If we've decided that radiotherapy is an important component of treatment for a certain group of patients, we then want to be able to refine that in terms of the amount of radiotherapy we give and the numbers of treatments, in terms of exactly how much of you we treat, because we've heard that treating bricks means that we might be getting the tumour in there, but we're treating quite a lot of normal tissue too, and that's what causes the side effects. And we also need to know how to safely combine the radiotherapy with other treatments such as chemotherapy and other agents that might make the radiotherapy work better. And in some instances, we can actually take radiotherapy, and because it's so targeted, so accurate, we can reduce the need for major operations. And particularly in some parts of the body, having major surgery is quite mutilating and can leave patients with long-term problems. Can we, with radiotherapy, be just as good as that but cause less damage? And actually, with some of the really clever techniques that are coming through now, can we actually do better than surgery? So what I wanted to do was just go through each of those points in a little bit more detail with some examples of trials that we've been heavily involved with in North Trent. As Judy said when she introduced me, I am a lung cancer doctor, so some of this will have a slight lung cancer bias. So we know that being involved in trials has really improved the quality of radiotherapy within the UK over the last few years. That we know that if you're not involved if your radiotherapy department's not actively involved in trials, that there's a tendency to fall behind in terms of implementing new technology. And when we go into the process of starting a new trial, our centre has to be scrutinised to see whether we've got all the techniques that we should have. We're then given a dummy patient, a lump of plastic, to treat, and the doctors are checked in terms of how they decide which bits to treat and which not to treat, and then the physicists are checked that they can actually deliver that safely to the patient. And only when we've passed those exercises are we let loose on real patients within trials. And a lot of those trials then require the radiotherapy plans to be approved by the trial centre before patients are actually treated. So this is a level of scrutiny that is very exacting and can take quite a bit of time to make sure that we're doing things exactly as the trial requires us to do it. And recently within our department, we've been involved in trials combining chemotherapy and radiotherapy for esophageal cancers, cancers of the gullet, which has changed and improved the way we deliver radiotherapy to that part of the body. And at the moment we're just starting a similar trial for cancers of the rectum, and again that's improving the radiotherapy and getting it much more targeted, much more focused, and we'll hopefully reap the rewards of that by seeing less toxicity in our future patients. So we've heard a lot about the newer radiotherapy techniques. You've heard about the intensity modulated radiotherapy where we can tailor the dose, and we got a lot of experience in how to safely introduce that technique in a big prostate cancer trial that we were involved in, and that required all of the different staff groups to work together, the doctors, the planners, the physicists, the radiographers who are actually delivering the treatment, so that we could all safely deliver that treatment. And at the moment we're heavily involved in a breast cancer trial using image-guided radiotherapy so that we can hit the spot, and that has really meant that the technical details of how we deliver radiotherapy to ladies with breast cancer has moved on enormously, and this is hopefully going to mean that ladies in the future will have much less in the way of side effects after their treatment. And we're also part of a UK consortium developing much more targeted radiotherapy for lung cancer, and that's called stereotactic radiotherapy, and this is where Chris showed you a picture of the CyberKnife. It's being able to deliver very accurate radiotherapy to very small tumours that are moving around because patients are breathing, and this may mean that we can offer radiotherapy to lung cancer patients who've traditionally not been able to have treatment that might cure them because the rest of their lungs are so damaged that it's not been possible to safely offer them operations or more conventional radiotherapy. So this was the prostate cancer study, and if you remember I talked about trials having arms. So on this one, if you had the right sort of prostate cancer, you could go down one of 3 different arms, and because we were targeting the radiotherapy much more accurately, we were looking at whether we could safely deliver the same amount of radiotherapy in fewer treatments and achieve the same effect or better, and cause less side effects because you weren't treating areas that you didn't need to. And you've seen lots of these pictures. So this is focusing the treatment very much on the prostate cancer and avoiding all those other things that you don't want to treat, such as the hips. And that's a picture showing you how we can paint the radiotherapy onto a breast cancer, but we're not treating very much of the lady's lung or of the heart, which are the sorts of things that cause problems in the future. And then that's showing a lung cancer being targeted in the same way. So we can do radiotherapy very accurately, but it's very important, it's very tempting if you've got all these lovely toys to play with them, but we just need to be really clear where radiotherapy offers additional benefits above and beyond treatments that are already being given. And a recent trial that we were heavily involved in that's actually changed the UK practice was for treating certain gentlemen with prostate cancer, where traditionally the main treatment would have been to put them on long-term hormones. And the question was, if we do that and the cancer shrinks because it's a hormone-responsive cancer, do we get any additional benefit if you then attack it in another way by also adding in radiotherapy? And we actually, this was an international study, and we were the biggest recruiters in the world, and it showed unequivocally that adding radiotherapy improved the number of people alive 7 and 10 years after their prostate cancer, and this is now the standard of care. Sometimes we know it's quite difficult to cure the cancer, but it's still important to keep it away as long as possible so that patients can stay well. And we may be able to debulk the cancer by shrinking it down with chemo or doing an operation. And the question comes, if there's still a little bit of cancer left at that stage, is it a good idea to kill it while it's small with the radiotherapy? Or is it better to give people a period of time off treatment and use the radiotherapy to settle things down again when the cancer causes more trouble? And there are 2 big lung cancer trials asking exactly that question at the moment in terms of different types of lung cancer who've had either chemo or surgery as their first treatment. And what's becoming increasingly important to us is looking at quality of life. And I know that Paul has already talked about the court study a little bit this morning, and this is for a very poorly group of patients, so that's lung cancer patients who've unfortunately had the cancer spread to their brain. Treating the brain with radiotherapy can be quite toxic. Your hair falls off, and people can be very tired and very sleepy for a long time, but it might enable them to be better in terms of controlling their cancer and not on quite such high doses of steroids, and therefore it might be a good thing to do in terms of quality of life. So looking at trials where we are measuring survival, but it's not the single most important thing. Actually, it's more about how patients feel is becoming increasingly important to us. So this is the prostate cancer study. So you either got hormones or you got hormones and radiotherapy. There we are, top of the pile. At 7 years after your diagnosis and the start of your treatment, if we didn't add the radiotherapy, in about 2/3 of those patients were alive, and if we added the radiotherapy in, about 3/4. So that's quite a big difference, and you can see over time that it takes a little time for that difference to show, because prostate cancer tends to be quite a slow cancer, but as time goes on it becomes clear that the radiotherapy did actually benefit those patients. And this is a patient with lung cancer, so they've got their lung cancer in their left lung there, that white blob at the top. It's gone away with the chemotherapy. So do we add radiotherapy in at this stage, or do we say, well, actually we've made you feel quite tired, quite unwell with your chemo, shall we stop at this stage and keep a close eye on you? And that's the question that the REST trial, we hope, will answer. And here's a slide that you've probably already seen. So this is quartz with patients who've got lung cancer which sadly has gone into their brain. What we're offering them is all the care that they would normally get, which is what we call optimal supportive care, and steroids to help them feel better, and asking if we add in whole brain radiotherapy, which is what that abbreviation stands for, will they do better, with the most important question being, how does that make them feel in terms of their quality of life? This is quite a difficult trial to recruit patients to at a very distressing time when they're often not very well. And because of that, the people who were running the trial felt it was quite important to do a check after the first 100 or so patients were recruited to make sure that there weren't any big differences, because, as I've said, if we were seeing big differences in the two treatments, we might not think it was ethical to continue the trial. And the check showed that in terms of the patients assessing their own quality of life, so this isn't doctors and nurses saying, yeah, they're doing great, this is patients assessing their own quality of life, that there was little difference between the two treatments, and therefore we felt comfortable to continue the study. Survival is an endpoint, but it's not the most important thing we're looking at in this trial. And again, it showed that the two treatments were probably equivalent, and confirmed that, sadly, when we're looking at this group of patients, we're looking at how many weeks they might be surviving rather than how many months often. And I think that makes it particularly important that we're not subjecting them to any unnecessary treatments or side effects for that relatively short length of time. And I couldn't find a more recent recruitment update. Western Park were a bit slow off the mark on this one, and I'll explain why when I get to the end of this talk. We were rapidly catching up most people. I don't think anyone's ever going to catch the Christie, and I think we've probably moved a few points up that league table now. So if we're happy that we've added radiotherapy and that's the right thing to do, the question then becomes, are we giving the right amount of radiotherapy, or can we achieve the same effect for fewer treatments, smaller treatments, and less side effects? So that's partly about the numbers of treatments that you give, which is what you've heard us call fractionation. And again, SCORAD, which I think Paul has mentioned, but it's so important I'm going to talk about it again. This is for patients who've unfortunately got the cancer in the bones in their back, and that's interfering with the nerves to their legs. When that happens, unfortunately, people start to lose the ability to walk. What we really want to do to these patients is keep them walking, and traditionally we've often given several doses of radiotherapy, but actually if we could achieve that with one treatment, it would allow us to keep those patients out of hospital and get them home, because we know as soon as you put a patient who's a bit wobbly on their legs into a hospital bed, then you've got to teach them how to use their legs again once they've been sat in that bed for 5 days. So it's about keeping people out of hospital and where they want to be, which is with their friends and family, and it's about reducing the inconvenience and the side effects for the patients. But actually it's also about using resources wisely for the NHS, because if we give 10 patients one treatment, I can treat 10 patients instead of giving one patient 10 treatments, and that keeps our waiting times down and makes sure that we're not delaying treatment for patients who need it for other less urgent conditions. The other thing that's changed enormously in the last few years is how many treatments we give patients for breast cancer. So traditionally, when we've done radiotherapy for breast cancer, it's been done every day for 5 weeks. That's quite a big chunk of your life. And a big trial done in the last few years called START looked at whether we could do that in 3 weeks instead of 5 weeks, and actually we could, with very little differences between the two groups. And I think for ladies with breast cancer, to get 2 weeks of your life back is actually really very important. And then for the lung cancer trials in this area, it's more about how we deliver the treatment. So cancers don't grow Monday to Friday and go home for the weekend. Doctors and hospitals work Monday to Friday, and therefore traditionally radiotherapy has been delivered once a day, Monday to Friday, and you know, goodbye, we'll see you on Monday. CHART was actually a treatment that was tested for head and neck cancer and for lung cancer, and used largely for lung cancer now, although it is for some head and neck cancers. And this was giving cancers radiotherapy 3 times a day and not stopping for the weekend. And actually that seemed to be better than doing it daily. And now the question is, can we add a little bit more radiotherapy to that and make it even more effective? And a similar sort of question in small cell lung cancer and the other sort of lung cancer, where again traditionally the radiotherapy is still delivered once a day, looking at giving that twice a day, so that instead of giving the cancer time to recover in between treatments, you're really bombarding it as hard and as fast as possible, on the basis that if you can get your treatment over as quickly as possible, the cancer never recovers in between, and that improves your chance of curing patients of their cancers. And again, just some pictures to reinforce some of the things that we've talked about. This is the SCORAT trial, which is for the patients who've got cancer causing problems with the nerves to their legs, and they either get one big treatment, which is the 8 Gray single fraction, or they get the more traditional treatment, which is the 5 fractions. And here, the single most important thing to patients in terms of how they're going to live the rest of their lives is whether they can walk or not, because if you can't walk, you can't look after yourself. And therefore it's very important that we understand how good they are in terms of their function in the study, because that's actually one of the really important questions this study is asking. You know, can we preserve people's mobility just as well with fewer treatments? And again, I couldn't find an up-to-date slide. On this slide we were the third, but I think we've moved round that pie chart now and are up there with Mount Vernon. So, we've talked about the numbers of treatments, but actually one of the really important things is the amount of you that we give radiotherapy to, because the more of you we treat, the more of the other parts of you we treat, and the more potential for us to upset those other parts, which is what causes the side effects. So when we use radiotherapy in combination with chemo and other agents, we've got to be particularly careful, because adding chemotherapy to radiotherapy isn't the same as adding 1 and 1 and getting 2. They often work synergistically, so they boost each other, and if you get it wrong, the potential therefore for lots of side effects is higher. But moving away from chemotherapy, are there other things that might make the radiotherapy work better in terms of trying to improve the effects of the radiotherapy on the tumour? And one of the illustrations of that is a bladder cancer radiotherapy trial. One of the problems with tumours are they tend to have areas where the cancer outgrows its blood supply, and therefore bits of the cancer are hypoxic or necrotic, so they're dead or they've got low levels of oxygen. And we know that you need reasonable levels of oxygen to make radiotherapy most effective. And what Archon was doing was giving the patients a tablet to try and open the blood vessels up, to try and improve the amount of blood getting there, to improve the oxygen getting there, and also asking patients to breathe a combination of oxygen and carbon monoxide, I think, to try and improve the delivery of oxygen from the lungs as well. And that did show that there was an improvement, and we now try and, it's actually logistically quite difficult in terms of getting the tablet into the patient at the right time, the gases onto the machine for the patient to breathe, but we now try and do that for suitable patients. But back to exactly how much of people we treat. This is really quite important, particularly if we're treating you for your head and neck cancer, because we cure a lot of patients with head and neck cancer when we treat them with radiotherapy. So if we do cause problems, they're going to be problems for a long time. And one of the important areas in the head and neck is your parotid gland, your salivary glands. And radiotherapy tends to damage the salivary glands, and you don't produce saliva. Now, if you've got a permanently dry mouth, that's actually really very distressing. It's very uncomfortable, but it also causes you significant problems with your teeth and your sort of dental hygiene, because you haven't got the saliva washing away all the bugs. So if you can use those really clever techniques to target the cancer in the head and neck, but to spare the salivary glands, then you can make quite a big difference to people's quality of life. And again, another group where it's quite important not to be giving radiotherapy to parts of them unnecessarily are patients with soft tissue tumours, which we call sarcomas. And these are often quite young patients, adults or even children. And traditionally, we've treated quite a wide area around the sarcoma because it has a tendency to spread up and down the nerves. and now we're concentrating much more on whether we can treat smaller areas and therefore mean that their arms and their legs are less damaged, and therefore they have better functional abilities in the future. And that's just to show you where the parotid gland is, just in case you don't know. It's that little one just there in front of your ears, the one that swells when we get mumps. And then finally, can we use radiotherapy instead of surgery? And I think one of the main areas we're looking at that at the moment, again, is another head and neck cancer trial, where patients who've had their cancer diagnosed quite late, so they've got the cancer in the glands of their neck, have traditionally had quite a big operation called a neck dissection, which, because it tends to make these tissues really quite fibrotic, and it tends to damage some of the nerves in their neck, tends to give people really quite a lot of discomfort and uncomfortableness, really quite solid. And we're now asking ourselves, well, actually, if our chemotherapy and radiotherapy is so good and we've killed the cancer anyway, why are we asking a surgeon to go in there and do those big operations? And we're using a technique called PET scanning, which is different to conventional CT scanning. What we've seen in the cross sections that Chris has shown us is the anatomy, so where things are and what they look like. That doesn't necessarily tell you whether things have got cancer in them. So you might have a big swollen gland, for instance, in your chest, but that might not be cancer. That might be a reaction to a chest infection. Or you might have a little gland that looks completely normal on your CT scan, but is actually full of cancer. And what we have now are PET scans, and this is where we give patients glucose, sugar, which has been labelled radioactively, and then cancers, because they are growing faster than most other tissues in the body, will use more glucose. So on a PET scan, anything that's hot, so any of those black areas, are generally active cancer, with two exceptions. The first is your brain, because that's always very metabolically active. If it's not, you're usually not very well. And your bladder, because you're going to wee out all the radioactivity. So the red bits at the top are the black bits at the top of your brain and the bottom of your bladder. And this is before treatment. This isn't actually head and neck, but it's just to illustrate it, where all the glands were really, really, really absolutely hot as anything. And then after treatment, they're not. So that's the heart, which is also metabolically active, because if that muscle isn't metabolically active, you've got a problem. And all those glands have gone away. So at that stage, we would be saying, well, perhaps we don't need to do an operation after all, because not only can we not see the glands on the scans, but it doesn't look like they're actually alive because they're not using any glucose. So we might be able to safely omit that big operation and just keep a really close eye on you and do the operation in the future if necessary. So 2 slides to close. The first is to say that some of these trials that we've talked about, particularly the palliative ones, so do we or don't we give radiotherapy to people's brains when they've got brain metastases, and the spinal cord compression trial, these are very difficult trials in very poorly patients. And sometimes actually the doctors sit there and go, this is too hard, we can't do this. I can't talk to someone who's just been told they've only got 8 weeks to live about whether they're going to have radiotherapy to their head or not. I'm not going to do that. But actually, sometimes it's you guys who change our mind. And the reason Western Park were very slow to get involved in courts, as we said, too hard, we can't do that. We've got a limited amount of time to talk to patients about trials. We've got a limited amount of resource in the trials office in terms of helping us run trials. It would take us months to set this trial up, and we don't think we'd be able to sell it to patients. Not going to do it. And then we were in a lung cancer conference in Dublin a few years ago, and a session that was put on there where Dave was a speaker it's changed my mind, and I went back and I persuaded my colleagues that we could do it, and we got involved, and actually we found we could sell it to patients, that patients think that this is a really important question that we're asking, and we can recruit patients into these sorts of trials. And then this one, we haven't quite got there yet, is just to remind me to stop talking. Thank you. Thank you very much, Trish. Has anyone got
got any questions? Nearly got there.
Not quite fast enough.
It's not really a question, it's more a comment. I think the very important things from that fantastic presentation, which makes me feel very proud to be part of the Western Park research department. It's how many times Western Park were up at the top and doing really well in those trials, and that is only down to the hard work of all the clinical oncologists at Western Park, the radiotherapy department, the medical physics. I think it's something that we should all be very, very proud of, and thank you. And it makes my figures look really good when I have to report experience on it.
Yeah, I think there's another reason we do really well. I think we have a great group of patients who are prepared to get involved. There was a big mesothelioma trial in chemotherapy that closed about 5 or 6 years ago, and the two biggest recruiting centres were Sheffield and Leeds. And patients in the south of the country just went, oh no, not having that, don't want to be involved. Whereas actually we've got a patient group who are really willing to consider going into studies and to help us answer some of these really difficult questions.
You still get the impression when you talk to the general public that they think that everything that the doctor offers them is evidence-based treatment.
Yeah.
And I'm not sure that we get that message across to the general public as this need for research. And I don't know whether you've got any ideas about how we can raise the profile of clinical research in all issues, not just cancer, with the general public. But and echo that question to the audience as well, that if anybody does have ideas, this conference was an attempt to raise the awareness of the general public. And it's wonderful that you are all here today, but I would have liked to have seen every chair full. And if we can't get that message across, then possibly we fail. I mean, any initial reaction to that, Trish?
Yeah, I mean, there's a lot of thought going into this at the moment. I know a couple of years ago you had John wanted to come and talk to you about trials. One of the things we're quite keen to do is I don't know whether it's succeeded yet, and perhaps Leslie might help me, is get a line on our appointment letters that go out that says, we are a research active centre and you may well be approached about a trial. I think it's getting that message over that actually, if you're not offered a trial, that's a problem. Because trials are really important in terms of advancing treatment. Trials are really important in terms of patient care, as we've said. There's quite a lot of evidence now that generally patients in trials do better than those who aren't in trials. I think oncology probably has more of an evidence base for the things that we do than lots of other areas of medicine. That's partly because what we do, if we do it wrong, is usually fairly disastrous. So, we have very powerful treatments. We have to use them correctly. I think Sam might be better at this one than me. Sam, do you want to say anything? Carry on. Thank you very much. We're also in the process of trying to come up with a new, I'm not supposed to talk about this, but I'm going to, a new motto and logo for Western Park so that we can relaunch ourselves. And actually we thought we'd come up with a logo, but we changed it because we added and research on the end of it. So our new motto is going to be excellence in cancer care and research. And we felt very strongly that research message right there, out front, even before you've ever thought you're going to need us, is important to get over. You can't quote me on that.
And can I just say that on the first slide that we had up today, the Western Park Cancer Charity puts research as the first word after the name of the charity, and it's fantastic to see that. Obviously, Western Park Cancer Research Charity, big supporters of research locally. But can I just say that to sort of further this, we're not going to close this conference today without spreading the word. And all of the slides and films of the presentations which have been made today will go will eventually be online, and we'll pass the links of those on to the general public via the National Radiology Awareness Initiative through Peter Zarko Flynn, who's been in touch with us and sent his best regards. But if you want to see the slides again, they will be made available later. Right.
Thank you, Dave. If I can just say, one of the comments you made before was that you recruited very, very well, and in other areas they didn't recruit as well as yourself. Speaking as someone who, I don't know if I'm supposed to say this here in case I get bleached, but I'm from the other side of the Pennines, we don't get asked. Now, it's very difficult for a patient, particularly a patient who isn't very well, to say, is there a trial I can go on? Because that's not what the way your brain is thinking. Your brain is just thinking, can I get better, can you do something for me?
Yeah.
And so I think maybe there's just as much education required of the clinicians in other places as there is of the patients to expect to be asked to go on a trial. You can expect all you like, but if you're not asked, it isn't going to happen. So I think we've got just as much education of the clinicians to, and I mean, like at home we've got clinical nurse specialists as well, because they're far more likely to get engaged in that direction. But it is definitely not so much postcode lottery, but postcode expectation. When I came here to the Sheffield ECMC, when we did an ECMC visit, it was delightful to walk into the hospital and see a poster beside me saying, well, this is a research centre, you will be asked to go on a trial. I haven't seen it anywhere else. So I think there is an education job.
No, I'm sure you're right, and the difficulty is that for every patient we got into those trials, we may have spoken to another 5 or 10, depending on the study. I talked about the Mars trial where I said I was gobsmacked every time someone said yes to me in terms of whether they would have an operation or not, and it wasn't their decision. On average, it would take us 10 to 20 hours of talking to patients before we got that decision. So clinicians are very busy, and sometimes it's a time thing, and actually I think that's very short-sighted. But also I think it's quite difficult for patients, because when you first meet us, you've got a lot of things you might want to ask us, including some really quite difficult questions. And then on the end of that we're going to go, and actually, because we don't really know for certain that we're doing the right thing, do you want to think about this trial? So that can be difficult. But also what some places are doing, and what we've been talking about a little locally, in terms of helping patients, because remember that Dave tells the story, I don't know whether we told it this morning, about his mum telling him off when he asked me a question about his dad's care. Sometimes it's as much about giving you guys permission to ask.
Yeah.
So it's some centres have a sheet for patients in the waiting room, and they say these are the sorts of questions you might want to ask your doctor. So it kind of gives upset, worried patients the permission to raise these sorts of things.